Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hey everyone, welcome to today's episode. Today we're going to talk about what type of doctor can help my lower abdominal pain. And we're joined today by two amazing women physicians, Dr. Pooja SInghal, who's a gastroenterologist and the director of the Women's Digestive Health Center at the SSM Health and St. Anthony Hospital. And then we have the amazing Dr. Arielle Allen, a urogynecologist at Urogynecology of Oklahoma. So this is going to be an amazing and a very candid interview today. We're going to talk about, it's a little bit of an embarrassing topic at times, and it can be a confusing topic. We're going to talk about some of the digestive health or bowel-related issues that may overlap or may mask some other serious issues that are related to more of the gynecological issues that women experience. Constipation, diarrhea, lower abdominal pain could also be indicative of something else going on besides IBS, for instance. It could be related to endometriosis or pelvic floor dysfunction, or in the worst case scenario, ovarian or rectal cancers. So we are going to get the lowdown on what we need to know. We're not trying to scare everyone, but knowledge is power, and this is going to be a really important episode. So welcome, doctors. We're so happy to have you here today.
Happy to be here. Yes, thank you, Jackie, for the invitation and discussing such an important topic that affects women all across the nation and world and is really underdiagnosed and under-talked about. So,
yeah, I think a lot of us as women, we're kind of tough with our pain, right? Especially during the time of the month. We just tough it out with the cramps, but there may be something else going on that gets more amplified during that time of the month. So we really want your help, both of you, to really understand what could be going on. So let's, back it up a little bit. And I know we talked about, dividing this up into three big areas to really focus on first. And one of the areas is the lower abdominal pain that we might experience before, during, or even after our time of the month. So could you give us a little insight on what that pain could be and what we need to know about it?
Yeah, I'm so thrilled that Dr. Allen could join us. We share quite a few mutual patients together, and one of the most common symptom presentation is lower abdominal pain. So I'll discuss kind of the GI perspective on it, and then Dr. Allen, if you wouldn't mind sharing your thoughts. But basically, starting off just basics of medicine, trying to localize where the pain is, the pain complaint from a GI perspective is very important. So whether it's lower abdominal, right-sided lower abdominal pain, left-sided lower abdominal pain, those are what we talk about as localizing areas. So on our right side, we consider appendicitis, diverticular disease, or inflammation of diverticular disease called diverticulitis. On the left side is, especially in the United States, we have sigmoid diverticulitis as one of the most common indication. And, the description of pain, whether it's intense, sharp, cramping, dull ache, also within the abdomen, we also want to be careful about the flank pain and the radiation of flank pain, whether it could be kidney stones, whether it could be coming from lumbosacral area, and more.
Okay, Dr. Singhal, now you got to talk the flank. People think of flank steak. Where is it in our body? And the other thing you said on the backside.
Yeah, absolutely.
It's over my head at this point.
No, absolutely. Thank you for the flank is on the side. Side pain. So the flank pain is the side pain. And that's also very important to kind of note because it gives us clue. As diagnosticians, we're always looking for clue when we're taking history. So from GI perspective, some of the important things to, make sure we identify right away is appendiceal infection or inflammation, which is appendicitis, diverticular disease, inflammation of that, and inflammatory bowel disease, ulcerative colitis, Crohn's disease. And lastly, and more importantly, not to miss any obstruction from colon cancer that can also cause diffuse abdominal pain.
So from a urogynecologic perspective, there are also several things that can cause lower abdominal pain or pelvic pain. When it's localized to a lower quadrant, like the right or the left, we think it could be a possible ovarian related issue, like an ovarian cyst. Something that can be done to easily diagnose that would be an ultrasound. If the pain tends to be more localized to the central area, it could be what's called adenomyosis, which is an enlargement of the uterine wall, where the endometrial glands can grow into the endometrial to the uterine wall and cause some discomfort, especially during a period, but can also be before or after. Endometriosis can cause pain before, during, or after as well. But endometriosis can be throughout the entire pelvis, not just localized to the center or one of the lower quadrants. Could be bladder related. There's painful bladder syndrome, which is something that I see in my practice frequently. There's not a whole lot known about that, but from other specialists, so it's often misdiagnosed. But it's something I see and treat a lot, and that can cause a lot of discomfort before, during, or after our cycle in the lower abdomen or pelvis. There are certain types of prolapse, pelvic organ prolapse, that can cause some discomfort, which we can go into more detail later if we need to. Constipation, which is Dr. Singhal's something that she treats frequently. Pelvic floor dysfunction or pelvic floor muscle spasms. The muscles in the pelvis can have dysfunction from several different things that can lead to discomfort in the pelvis as well, or lower abdomen.
Okay, doctors. So as a woman, what do we do? We may have this lower ab pain, and it may be accompanied by constipation or diarrhea. How do we know what to treat? Do we go to the drugstore and get something to treat, like Tylenol? Do we put some, hot water bottles on it, or heating pad? But in more seriousness, how do we know who to see and what to do?
That is a very good question. What specialists do we see when we're having these pains? I always suggest starting with your primary care provider first, whether that's a family doctor, an internal medicine doctor, or an OBGYN. Those can all be considered primary care physicians. And mentioning the symptoms, the location, the timing, is it in relation to a cycle or not, to your menstrual cycle or not? Is it related to any other bladder symptoms? Is it related to bowel symptoms? Are you having difficulty with bowel movements? Stating these symptoms to your primary care doctor can help that physician determine which specialist that patient needs to see.
Absolutely. I couldn't agree more. I think from our perspective also, it's very important, and something that is critical and very useful to us is just kind of having a symptom diary. Just like a week-long symptom diary. So is the pain in any relation to bowel habits, whether it's constipation, whether it's diarrhea? What does constipation really mean to you? Is it a feeling of incomplete evacuation? Is it the stool consistency or caliber changes? Is it frequency of bowel movements? And any triggers or alleviating factors. So whether it's food intake, whether it's movement that's making a pain worse, whether it's menstrual cycle, relation to menstrual cycle, all these important factors in history is very, very important for primary care physicians to help delineate who to send, and first to diagnose, and then who to potentially refer to get the help very, very fast and in an efficient manner.
Well, it's great that you just said that, because my next question was going to be about, keeping track of the symptoms, because a lot of times we may not have an appointment for 30, 60 days from our onset of our symptoms. And by that time, I know I'm guilty of it. I've lessened the impact of what I'm feeling, and it's not a big a deal because it's 30 days or 60 days since I felt really bad pain. And it's like, oh, it's okay. And really, it's not okay. So I really want to stress the importance of keeping the diary, but also making sure that you're doing it so that you understand what's happening during your cycle and after your cycle. And there are things that could be happening. And if you could notice a pattern, if you write it down, like Dr. Singhal said, which is going to help either one of you to help with the proper diagnosis and ultimately treatment. So this is critical. I 100% agree with you.
Yeah. And I mean, one thing that you said is very, very important, Jackie. And I'm so glad you said that. We're kind of in the post-COVID pandemic era where the care is so delayed. I mean, some patients are waiting up to 90 days to see specialists. And the key is, Yeah, the key is to figure out, even if the impact is lessened by the time you see the specialist, our job is to make sure these symptoms don't recur, because that's really the big thing, so that it doesn't just stop the quality of life all of a sudden again.
Yeah, because you may know in that 90 days that you did something differently.
Yes.
That you didn't do before, but the doctor would want to know that, and you want to keep on doing that.
Yes.
Hopefully.
Yes.
Yeah, so, very important for the diary to add those things.
And now what are a couple of things that could be wrong with the lower abdominal pain, and what should patients know about that, and what could they expect, once they go to either the primary care, and if they're referred to you, Dr. Singhal, what were some of the things that they would address? And if they're referred to you, Dr. Allen, what would be some of the things that would be addressed? So if you can kind of so I have abdominal pain and I was referred to Dr. Singhal because it was more gastroenterology related.
Absolutely.
So what are some of the things that I could have, and how would they be treated potentially?
Absolutely. If one thing to take away from this podcast, my recommendation would be, if you're having lower abdominal pain and you have fever, chills, blood in stool, or you got to seek care right away. There's no reason to get delayed. So I hope, do not ignore if you have lower abdominal pain and you have fever, for example, because that could represent infectious colitis that may need antibiotics right away and cannot wait 30 to 60 days. It could represent inflammatory bowel disease, Crohn's disease, ulcerative colitis, and a lot of people have misunderstanding that they have to have family history for those diseases, and you don't. It could represent diverticulitis or appendicitis. So just lower abdominal pain and fever, seek care. Lower abdominal pain and bleeding without even fever, seek care, because that could represent colon cancer. It could represent a bleeding diverticulum. It could represent some colonic bleeding that requires intervention right away, like mesenteric ischemia.
Oh, wow. It sounds pretty serious.
Actually, that one is. That's why
that's an emergency.
Yeah.
Yes. Don't delay. Get help. And what if the person was referred to you more of a pelvic floor issue, or more urological issue?
So pain from a urogynecologic issue is not going to be as emergent or urgent as GI. If a woman is having pain in the pelvis, it's unlikely, not possible, not impossible, but unlikely to be a cancer, like a uterine or a female gynecologic cancer, and it's unlikely to be a bladder cancer. Those typically do not cause pain.
Okay, that's good to know.
Yes, typically, but still, don't delay care. You should still try to seek care, still try to get referred to the appropriate specialist. If a woman is having pain in the pelvis, and say it's related to intercourse, before, during, or after intercourse, that can be a pelvic floor dysfunction or musculoskeletal dysfunction. And that would be something that a urogynecologist could diagnose on exam in the office. And there are great treatment options for that. Pain and difficulty with defecation or having a bowel movement can be related to a certain type of prolapse. There's something called a rectocele, where the rectum actually falls or bulges into the vagina, and that can cause pain with defecation. Oh, wow. Yeah. A lot of people don't even know that can happen, but yes, it certainly can. It can cause difficulty and pain with defecation. Again, symptom diaries are great for this, because I need to know, is the pain related to bowel movements? Is it related to intercourse? Is it related to having a full bladder? If a woman complains of pain mostly when their bladder is full, that leads to me to think that it might be related to the bladder and might be painful bladder syndrome. Those are all pelvic floor related issues that I see in my clinic as a urogynecologist.
So what about women that may think they have a urinary tract infection, and they kind of just, do the same thing that they've always done, but could that be indicative of something more serious, like a pelvic floor issue, or that they should see you for?
Yeah. So when women have recurrent urinary tract infections, which is defined as 3 culture proven UTIs in a 12-month period, So if a woman has recurrent UTIs, they do need to seek evaluation by a urologist or urogynecologist. And that does require an appropriate level of workup where we evaluate the bladder and the entire urinary tract for any abnormalities that could be leading to the UTIs, the actual infections.
This is very interesting. And it's also almost like overwhelming because our bodies are so fine-tuned and they can overlap, and you could feel so much, especially as women, we're so in tune a lot of times, but we either want to make assumptions about what it could be, and we could make the wrong assumption. Let's talk a little bit about, one of the other, we get lots of emails about this. We get lots of questions on our, channels and social media about constipation. It's such a hot topic. Everyone at one time or another has experienced what that is. But then there's people that have chronic constipation issues, the ongoing use of laxative to no avail, and this vicious cycle. And I really want to bring in both your roles, like how you see this in practice, Dr. Singhal, and then when they finally get to you, why and your important role in the pelvic floor. Like, let's talk about that. The patient who's just ongoing chronic constipation for years and years to no avail. And I'm sure it's like, what do you do? And I'm sure you see this in practice a lot.
Absolutely. Absolutely. I mean, constipation is estimated to affect about over 30 million adults in US, and that's just adult population. So it's very prevalent, and it is a nuisance really, because it affects quality of life. Patients suffering from constipation are miserable. From my perspective, again, we are all detectives, and the more clues we can get, the faster we can diagnose and the better we can manage. So from my perspective, you have occasional constipation, you have irritable bowel syndrome with constipation, you have chronic idiopathic constipation, and then you have something called dyssynergic defecation, which basically means the sphincters are not working, and that's where the pelvic floor is not working. And that's where it's so important in females to get proper management. So I'll address kind of the first three. Again, I always say, if you're 45 or older and you all of a sudden started having bowel habit changes, including constipation, and you got to get proper evaluation, which is a colonoscopy, because we're seeing colon cancer in younger and younger patients. So there's absolutely no ifs and buts about that. So that's number one. Number two is I always ask my patients, what does constipation mean to you? And that's usually very telling to me. And, sometimes to people, it means I haven't passed stool. I pass stool once a week or once a month, and it gives me degree of severity. So constipation is defined as less than 3 bowel movements per week. Usually. Then also this kind of feeling of incomplete evacuation, and that's also very, very important. And from there, I diagnose them whether they have abdominal pain and they meet Rome 4 criteria for IBS. If they don't have abdominal pain, then they may fit chronic idiopathic constipation. And of course, ruling out other things like hypothyroidism, which is a common cause of constipation.
Oh, interesting.
That's my general approach, to constipation and diagnosis of constipation. Of course, there's treatment, but I'll let Dr. Allen talk about.
Yeah, Dr. Allen, tell us about the patient who comes to you after the gastroenterologist has done all they possibly can, and they think it may be a pelvic floor issue, so they would refer to you. Is that what happens in your? Because you guys work together, right? You refer. So
Absolutely.
tell us a scenario that happens, and I'm sure it happens again and again and again, and what the patient can expect from going to you.
So the two main pelvic floor related causes of constipation that I see in my clinic, and that are probably the most common, are what's called erectocele, which I mentioned earlier, which I'll talk about here in a second. And Dr. Singhal kind of mentioned a pelvic floor dyssynergia, or where the muscles do not work correctly in sync to allow for normal defecation. And so these are things that can be diagnosed easily on an exam in my office. So these are that I see and find on exam. A rectocele is like what I said earlier. It's where the rectum actually falls or bulges into the vagina and then bulges out of the vaginal opening. The two most common symptoms of that are feeling a bulge at the vaginal opening and difficulty with defecation, like difficulty emptying with bowel movements, or some women will describe it as constipation. And again, that's where what does constipation mean to you? How do you describe your difficulty with your bowel movements? What makes you think you're constipated? That helps us figure this out. But a rectocele is seen on exam, and there are great treatment options for that. The other common reason for constipation that I see in my clinic is the pelvic floor dysfunction, when the muscles of the pelvic floor do not work in sync and they don't allow for normal passage of stool. And again, diagnosed on exam, and there are some great treatment options for that.
Now, are there risk factors or something that would contribute to that more than others? Pregnancy, age, running too much? I don't know.
Age is a big one for pelvic floor prolapse or the rectocele. Age is a big one. And having babies, vaginal births, that is a big risk factor. And there's a genetic predisposition. So when women say that their mother or their grandmother or their aunt had prolapse of some kind, then they are more likely to have prolapse.
Yeah, absolutely. What about prior surgeries, Dr. Allen? I actually am curious about that. Prior obstetric or gynecological.
Oh, like a hysterectomy?
As a risk factor for a prolapse or just pelvic floor? So yes, so she brings up a good point. Pelvic surgeries of almost any kind can be a risk factor for pelvic floor dysfunction. And I see that sometimes related to bladder emptying issues as well as bowel emptying issues.
So, I mean, it sounds scary to have a bulge in that area. And I hope we're not scaring anyone who's listening, but this is educational.
Yes.
So now we always like to add some hope and, information so people can feel like this is not the end of the world. If this is happening to you or you think this is happening to you, what kind of treatment options are available and can we fix this?
So a bulge at the vaginal opening is never scary. It's not a sign of cancer. It's not going to be scary. So I don't want to scare anybody. And these things are fixable and have great treatment options. Some require surgery, some do not. There are plenty of types of prolapse that do not require surgery. So there is a great treatment option called pelvic floor physical therapy, which is where a patient sees a physical therapist who specializes in the female pelvic floor. And so they see women all day long that have these kind of issues and can provide great therapy treatments for the pelvic floor.
Yeah, we talked to one, I think last year, but it's not on our YouTube channel. It was an audio podcast. I'm thinking of inviting her back. And so she can maybe demonstrate some of the exercises that she recommends and works with her patients, because I think that's so powerful. And it was really eye-opening to hear her talk and how she's, helping people, helping women, especially.
Yeah, I think it's so great that we have Dr. Allen, urogynecologist, with us, to share this. And I think one of the things, in addition to symptom diary, is advocating for yourself. Yes. Because once you start writing and, hopefully after listening to your podcast, kind of identifying those patterns, asking for the right specialist is also very empowering to be able to advocate for your own health. Now, coming back from my perspective in constipation, there's a lot of hope. We have some great treatment options for after ruling out any, obviously colon malignancy. And even if it is colon cancer, we have great options of treatment in 2023. But for constipation, IBS constipation, we have multiple new medications that are GCC agonists, like Trulance or Linzess, or even a trial of Miralax, which is polyethylene glycol with fiber, I think is very can lead to a lot of relief and living good quality of life. One thing I will say that's very easy to do at home, and this is related to our female anatomy, is just having a stool like squatty potty, and that makes you raise your legs a little bit to pass stool and opens that angle to be able to avoid straining and promote good anorectal health, prevent hemorrhoids. It's very easy to do. Put a stool, lift up your legs. Human body, especially female body, was always meant to squat and pass stool. Wouldn't you agree?
Oh, yeah.
That's the way our bodies were made, and that's the way we're meant to actually. It opens the pelvis up the best.
Yeah.
To be in that position.
Isn't that the way some countries have babies, right? They squat.
That's right.
Yeah.
And that position actually does open the pelvis up the most to have babies as well.
Exactly.
It sure does.
Oh, that's wild. So I know we could talk about these all day, and we'll definitely have you guys on again to delve into more of these topics specifically. There's so many, but I really wanted to raise awareness and give some hope for women who may be struggling with figuring out, like, why am I having all this pain? Is it related to being a female, being a woman, or is it related to a digestive health issue? And I don't know what to do. So we definitely wanted to have you both on. But one of the things that you talked about, Dr. Singhal, was, the bright red blood, seeing in the rectal area. And, we've been taught, if it's bright red, don't worry about it. It's the dark blood that seems like it's an internal bleeding issue. But I want you to correct us on that.
I am so glad you brought that up, Jackie, because that is, even in last 15 years, that's changed. When I was training, a 40-year-old female or male walks in with bright red blood, we are thinking hemorrhoids or anal fissure, which just means some tear that can happen in anal canal, especially with passage of hard stool. But that has completely changed as we're detecting advanced polyps and colon cancer earlier and earlier. So it's very, very important. And I still all the time have patients in my clinic, and they come for constipation, and they're like convinced. I have to really tease it out. Do you have blood in stool? And they're like, oh no, it's my hemorrhoids. While I appreciate everybody knowing their body the best, bright red blood, whether it's on toilet pipe, whether it's on the surface of the stool, it's still very important to seek care, at least have a digital rectal exam in the office by a specialist or a primary care provider to make sure we're not missing anything, and especially a good recommendation of diagnostic evaluation, so we are not missing rectal cancers, which can also present as bright red blood, and also colon cancer. Lower sigmoid colon cancer can cause bright red blood too. And lastly, proctitis, inflammatory bowel disease, whether it's ulcerative proctitis or ulcerative colitis or Crohn's.
And I want to, just talk about the digital rectal exam, why it's so important. It may not seem like it's your favorite thing to do, not you, but a person, but for patients, what do you want to tell them so they're not scared or feel embarrassed about this examination?
Yeah, at least in my office, we are very respectful, and we are very conscious of the fact that it's a vulnerable position to be in. So first of all, I would like to say the digital rectal exam, takes maybe 2 minutes, and that's like a good exam. Endoscopy takes digital rectal exam with endoscopy, which is just putting a little bit of scope and seeing the anal canal, takes maybe another 2 to 3 more minutes. So it's a fairly quick procedure. It is uncomfortable, but it's not really painful. And we are, everybody usually in healthcare is committed to keeping that modesty and doing this with a lot of respect and care. So please know that we are very aware that this is not a comfortable position to be in, and we are just trying to do whatever we can, whether it's using warm lube so you're not more comfortable, whether it's my assistant holding a patient's hand and just being at every step of the way.
Well, that makes that definitely eases my mind for that, but it's good to know, because I think everyone, not everyone, but there may be people listening who may be a little fearful of that. And I hope this helps them realize that it's very professional and respectful, but a very important exam. So before we go, I just wanted to sum up with some tips and guidance for patients who maybe experience, whether it could be a potential pelvic floor issue or a digestive health issue? Like, what do you recommend? And I'll let you go first, Dr. Allen. What do you want to say to patients to sum up and give them some tips and guidance?
As far as trying to determine if you have a pelvic floor issue or not, I think the symptom diary is probably the most important thing. Trying to find out where your pain is located at the majority of the time. Is it related to anything you eat, you drink, your activities, your menstrual cycle? If it is related to anything related to intercourse or vaginally in that area, or with your bladder, that very well may be a pelvic floor issue, and you might need to see a urogynecologist.
I love that title, urogynecologist. I've never heard of it before. That's great. Yeah. It's an important area.
It is. It
is
very
right.
much is. Mm-hmm.
And I love that you work together. That's so important, this multidisciplinary care team approach that really helps the patient.
It certainly does.
Absolutely.
Yes.
Absolutely. And that's why this is so important. I'm so glad, Jackie, that you're doing this, because women's health is so important. And any time we can decrease those barriers, I think we are empowering all of us. And from my perspective, I think Dr. Allen summarized it. Symptom diary is very important because, again, we are detectives. Think of us as detectives. So the more clues you bring to the visit, the faster we can diagnose you, the faster we can get to the right treatment, the minimal testing will be needed because you're giving us all the information, and that's critical. And secondly, GI specific, if you have lower abdominal pain and fever, seek care. It's acute, it's urgent. If you have fever and if you have lower abdominal pain and bleeding, seek care. That is not something to take for granted. It's, it requires evaluation. So we can help you get the treatment very, very fast in an effective manner.
Well, doctors, this has been so enlightening, and I hope that our listeners find this very helpful and empowering so they can get to the care and make their appointments after filling out their symptom diaries properly. But this is a really important episode, and I look forward to following up to delve down into some of these topics with a little more granularity. But thank you so much, and I appreciate both of you. Have a great day. Thank you.
Thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.